Hey everyone, welcome back. For those of you who are interested in having a one-on-one conversation with me, where we can go over your Oscar data, your sleep study, or just your overall sleep disorder breathing profile, try to find some answers, I've left a link in the description box below, where I will also put Dr. Rama's contact information and website details. Good luck everyone, and I hope that you guys find some answers in this video. To infinity and beyond.
And actually, I didn't look at any of them. And I'll mention that before when we actually start that I asked my team to just find 10 WatchPAT sleep studies and just blot out the names. And they asked me which ones. I said, I don't even care. Just pick 10 in a row. Done. So that's what we're doing right now. We're going over 10 WatchPATs in a row. And yeah, maybe it's a waste of time. I don't know.
Nah, I think it's a good idea. WatchPAT is... People have their criticisms, but I think it's the best sort of standardized commercial product that we have, right?
You nailed it. People have their criticisms. I mean, I don't think people think I'm overly a fan of it, but among what's out there, yeah, if you're going to get a home sleep test, do a WatchPAT.
Yeah, and the best part about it too is just it's standardized. We want standardization, right? There's no standardization in this area. I went off about that on one video. It's like nothing's standardized. Everyone's doing their own thing. Like this sleep study, that sleep study, we'll mark it like this, we'll mark it like that, right? This just doesn't work.
Yeah, the interscore reliability for a WatchPAT is 100%.
Okay, well, look, I mean, off the top of my head, I already am wondering, like the Epworth sleepiness scale, is this typically included in the report somewhere? And if so, what's the significance? What are we doing with that? And then also the neck circumference. Why are these relevant? Why are these included in the table?
Well, when you register the WatchPAT, you can put in any type of information you want. You can put first name, last name, whatever patient ID you want, mail, address. If you want to add the neck circumference, Epworth sleepiness scale score, BMI, you can, but you don't have to. At a minimum, people should add the first name, last name, and an ID, and preferably a birth date, right? But it's not necessary. You can, at a minimum, you need an ID and a first name and a last name. That's it. Everything else is optional to the clinic that you work with. Now, if we have this information elsewhere, it just takes more time to type it into the software when you register the patient. So why is it relevant? Well, there's a link between a large neck circumference and obstructive sleep apnea. And the Epworth sleepiness scale score is generally a little elevated in people with sleep apnea.
And how do patients even get the study? Is it you that has to like send them, whoever makes the WatchPAT, like a message? I need I got a prescription for a sleep study. I want it sent to this address, and then it goes to their address? Or how does that work? Or do you just give it to them in office?
We just hand it to them in the office.
It's a box, right? Here you go.
Box. All you need is a AAA battery that's brand new. Ideally, you have a piece of medical tape because it asks you to adhere something over that tape. Maybe later you can actually add the 4-minute how to use a WatchPAT video that's on YouTube on your channel, right? And include that in some way, and people can see how easy it is to do. And then you put a PIN number, and we always use one same PIN number to make it easy, and they're off to the races. We use the WatchPAT 1, which means it's disposable, so they don't even have to return it. There's no inventory to manage. They can just discard it, and once it's downloaded, it goes to the cloud, and then we have our software and we can review the data immediately.
Is this a modem type thing, or do they have to hook it up to their Wi-Fi and then it transfers the data?
They have to download the app on their phone.
Okay.
And then once they press download, it goes into the cloud, and then we have our software called the CloudPAT, and we can pull in the report, and then we read it. And this is actually the reports that spit out, and you add your diagnosis and recommendations.
Okay, interesting. So it's all auto-generated.
It's all auto-generated, and the study is auto-scored. Basically, it's scored by AI, whatever proprietary algorithm that they have. And typically honestly, I've probably overseen 50 to 100,000 WatchPATs in the various 20 years I've been, overseeing this product. And it's rarely hand scored by the doctor. Rarely. I mean, one in maybe 100, it's very rare. The only time I do it, I hand score it, is if there's electromagnetic interference. And sometimes the study does not come out properly, and you have to go in and remove some of those electromagnetic interference artifacts. And that's about it. Apart from that, even I don't hand score them. I just take it for what it is. It's not, for a home sleep test, I think it's good, but it's a home sleep test.
Okay, but if I'm understanding correctly, on your guys' end, like on the healthcare providers or the physician's end, you do have the option to basically override the results if you want to, right?
You do have the option to override the results. And technically, the American Academy of Sleep Medicine says that you should be hand scoring and reviewing all the raw data for each WatchPAT. And
But no one does it.
I can just tell you no one does it. And if they are, they're lying to you. There's no one doing it.
Can a patient see in the report where, or even just if, a physician has overridden the report?
The patient cannot see it, but on the CloudPAT software, there's a record. Everything is chronologically maintained that this was overread.
Okay, that's all I think I have for this page.
Oh, okay, yeah. This is just so, Andrew, like we said, we're going over I asked my team to assemble 10 random, not even random, 10 consecutive WatchPAT reports. And I'm going to let you know, I haven't even seen this. I said, blot out the names, give me 10 in a row, good or bad, I don't even care. And we're going to go over on Andrew's podcast what these 10 are. So let's just go over the first one. And then you go over the recommendations. I'm going to leave that out for now. And I'm just going to go to the data. Okay. And so this is the data for the first thing. So the first thing the WatchPAT tells you in the top, can you see my cursor, or is that?
I can, yeah.
Okay, perfect. So there's a start time. That's basically when you press start. So this person started the study at 1 in the morning, 1 a.m. And then obviously when he presses done sleeping and you press done sleeping, download data, that was 8:06 a.m. So the total recording time was 7 hours and 2 minutes. And now the total sleep time is 6 hours and 39 minutes. So
how accurate is that?
I think it's reasonably accurate, right? It's about as accurate as your Aura Ring, your Fitbit, your Apple Watch, all of those other things. It bases it on various parameters. I think what's nice about the WatchPAT is that when you do some of these other home sleep tests, they don't actually look at sleep time. It's pretty much when you start it and when you end it. And they don't have the ability to remove the time that you're awake. And so your numbers might come out, a little different with those studies. And then I don't know why, but they put percentage of REM sleep time right on the front panel. It's not something I would have done, right? But they do that, right?
I think that's a little marketing play, because everyone likes to talk about REM. It's in vogue, and it's important, by the way.
And normal REM sleep for an adult is about 20 to 25% of your sleep. So whatever, this person is normal. And then these are the numbers that, and I'm gonna highlight PRDI, PHI 3%, and so on. So what do these numbers mean? Well, let's start at the bottom. ODI, that's the oxygen desaturation index. Oxygen means oxygen, desaturation means it drops, index means per hour, and that means a 4%. So how many times did your oxygen drop 4% per hour? And that number is 15.7 times per hour. Okay. And the total events was 94, but the index is 15.7. That's why it's highlighted. And interestingly, is usually we have a separate column, that's all night. Then we have a non-REM column and a REM column. Typically, if someone has a compromised airway during sleep, it's more compromised during REM sleep because your skeletal muscles relax and and you're more likely to inhibit your airway. But in this particular case, it was actually the opposite. It was a little bit worse in non-REM versus REM. So part of what I do when I read a WatchPAT is I try to validate it in my mind. Do these numbers make sense? So this already doesn't make entire sense. Does that make sense? Hey, that's a little bit strange. Why isn't it worse in REM versus non-REM? Then we have the PHI 4%. The P refers to a WatchPAT, P, And then the A refers to an apnea, which is, usually a 90% reduction in your airflow. And in this case, it's not using an airflow, it's using, a surrogate of that. A hypopnea usually refers to a 30% reduction in breathing with an arousal or a 4% desat in this case, right? But once again, I'm not sure how good the WatchPAT is in distinguishing a hypopnea with arousal versus a RERA, right? So that because it doesn't actually measure precise airflow. Anyway, and index is per hour with a 4% drop. So it happened 204 times or 34 times an hour. Now, this is Medicare criteria. So Medicare is using 4%, and I believe some commercial insurers are starting to use 4%, because you're less likely to reach that threshold. But in any case, the AHI is generally considered normal if it's 0 to 5. If it's 5 to 15, it's considered mild sleep apnea. If it's 15 to 30, it's moderate sleep apnea. And if it's 30 and above, it's considered severe sleep apnea. Now we're going to go to remember, this is the first one, Andrew, so it's going to get much easier as we go through the rest of the P is the WatchPAT again. AHI, complete interruption, partial interruption, index per hour, but central apneas. So how many of these were centrals and that caused a 3% drop? Well, there's only 4 of them. So all of these events is 0.7 per hour, and that's totally normal. Under 5 per hour is normal, usually 1 or 2. And so all of these events were, quote, obstructive. The ODI 3% oxygen desaturation index, meaning how many times did your oxygen drop 3% per hour? It was 379 versus 94. So you can see that just going from 4 down to 3% was a huge difference. Does that make sense? It was much easier to drop 3% than it was to drop 4%. So
why are we doing this? It just seems like an effort to confuse everyone. Why can't we just decide on 3% or 4%, or even put it in the middle? Let's reconcile it. We'll put it at 3.5%. Why do we do this?
Well, my guess is the insurance companies prefer 4% because it's less to cover. And I think people with symptoms prefer 3% or even less because, they're symptomatic. But you're right, it's very arbitrary. And what I'm pointing at is that you could have sleep apnea or not sleep apnea, mild, moderate, or severe. It could all change depending on which criteria you look at. Like, are you looking at the Medicare criteria, the non-Medicare criteria? Are you looking at the RDI? And so 100%, Andrew. But you know what? It's just the system that it is, right? We can't change it. We can't move the Titanic. Anyway, so the ODI 3% was 63 an hour, and that's, that's a lot. That's a lot of drops in oxygen per hour. The PHI 3%. Now you would think that these two numbers are very similar with the WatchPAT, when the PHI 3% and the ODI 3%, just like the PHI 4% and the ODI 4%, but sometimes they're variable. In any case, the PHI 3% just says, using a WatchPAT, how many times did I completely or partially have interruptions in breathing per hour, causing a 3% drop? And now it's 389 times, or 64 an hour. And you can see I told you severe is 30 or more. That's double the severe number. But once again, hey, it wasn't worse during REM versus non-REM. That can be the case, but it's a little less common, right? Now, looking at the PRDI, what I usually find is that when the AHI is very high, so the RDI is using a WatchPAT, what's the respiratory disturbance index? And what that means is that that's the total, that's the number of, that's the interruptions of breathing that technically cause an arousal, not necessarily a drop in oxygen. And there's only an additional, 0.6 more per hour. What I find with the WatchPAT is that when that AHI is very high, the RDI is usually kind of close to it. But when the AHI is low, then there's more more room for the RDI to be higher. And so basically, they're basically the same. So I think taking this away, this person would have severe sleep apnea at the surface. It's not worse during REM sleep. Even using the Medicare criteria, it's severe. And then if we look at the oxygenation, the mean oxygen is 94%. So what's normal? Most people should be around 95, 96%. Okay. So sometimes that's low because they've had so many cyclical desats during the night that it brings the overall average lower, right? But other times it's just they have a low oxygen. And it's just something to look at, right? Do they have any pulmonary disease that we're not aware of? The minimum oxygen is 89%. Now, what I think is that when your oxygen drops down to 89 and above, it's a mild drop. It's mild. When it drops to between 80 and 88, it's more moderate. And when it drops below 80, it's severe. That's just my personal criteria, right? So this is a little strange. This person has severe sleep apnea, but only a drop in oxygen down to 89%. This is where I'm going, that sometimes I like the WatchPAT, but sometimes I question its results, right? So we're labeling this person as severe sleep apnea, but the oxygen doesn't make sense. Can you really stop breathing 65 times an hour and only have a drop in oxygen down to 89%? That doesn't sit perfectly well, right? And you can see that the severity of oxygen drops in the WatchPAT. How many times has this gentleman dropped 3 to 9%? Versus 10 to 20% versus greater than 20%. Well, all of them were 3 to 9%. They're all mild ones. But how much, and then if you look at this, how much time was spent below 90%, below 88%? You can see it was 6 seconds. It was 0.1 minutes. So that's a little strange. Can you really have 65 interruptions in breathing and only be, like under 90% for 6 seconds? That's a bit strange too. But let's keep going, right? And then we have the mean pulse. The mean pulse is 76. Now, look, I read a lot of sleep studies. That's high, so that's a high mean pulse. Most people, I'd say if you're not in shape, are in their 60s. If you're in pretty good shape, you're in your 50s. If you're in great shape, in your 40s. And if you're an Olympian, you're in your 30s. That's what I typically see, right? But 76 is high. The normal range for a pulse when you're awake is 60 to 100. Minimum 60, maximum 100. The normal range for a pulse when you're asleep is 40 to 90. So at the surface, you could say, well, this person is elevated. His minimum is 53, not 40, and his maximum is 114, not 90. But the reality is, if the mean is elevated, then both of these numbers will naturally be elevated. So that also, it's like, oh, that's interesting. Let's say this gentleman should have been 65. Well, then this would have been 42 and 103. It's still a little elevated, but more in line. But once again, it's a little different. Why is this person's pulse that fast? And then this is just a graphic, and it shows where this person is on the sleep apnea, and it only has the AHI, and it says, oh, it's very severe. I asked the company, can you please put RDI on there, because that's officially the International Classification of Sleep Disorders uses RDI in the diagnosis of sleep apnea. And it's, if your RDI is 0 to 5, you're normal. 5 to 15 with symptoms, you're positive. And so on, right? But they said they couldn't do it. So I said, okay, whatever. I guess it's technically not possible for them to put that on there. So on the next page, it goes over, there's a few hypnograms, so to speak, right? And there's the first one is the PAT respiratory events. This is peripheral arterial tonometry respiratory events. Basically, peripheral arterial tonometry, what that means is that, obviously there's no, with a WatchPAT, it's just something on your hand, your wrist, something on your finger, your wrist, and something on your neck. That's it. And there is nothing on your chest. There's no belts, so to speak, right? So how does it know if there's a cortical arousal? How does it know? Well, because it's measuring your arterial constrictions. So every time you have an arousal, your sympathetic arousal also usually, the heart rate goes up, breath rate goes up, and your arterial constricts just a little bit, right? And that's what it's measuring. But frankly, I never look at this. I never look at the PAT respiratory event line on this. Now the next one is snore and body position. The orange is snore. And this is obviously longitudinal through the night. And so this is also a little unusual. For someone who has 65, whatever, interruptions an hour, there's not that much snoring. It's just a little bit. I mean, it's actually, not too much at all. The other, and on the right is the decibels. In decibels, what it is. So it almost looks like there's a few snorts, so to speak, but not necessarily sustained snoring. And in decibels, usually 60 decibels or more is considered a lot. So from about this point above. And then the other line is the body position. Supine means on your back. Right, left is obvious. Prone means your stomach, and sitting is where you're upright. And so you can see this person went from his back to stomach to right side to back to left to back to left to back to left. Well, you get the point, right? And so after a while, you get an idea of, okay, is this a lot? I think this is a little excessive. I think this patient's sleep is a bit kinetic. They do move a little bit more than maybe they should. The next one is your oxygen saturation. So you want to ideally be above 90%. So once again, it looks like it's a dirty signal. It looks like there's a lot of teeny drops, but are still contained mostly within the 90%. And you can see it only dropped below 90% just one time. So I think it's real because it occurred in a cluster of oxygen desats. So I do think that low of 88 or 89%, whatever it was, is real. And the next line is the heart rate volatility, the pulse rate. And you can see that it's pretty steady but see, this is also a little questionable when it kind of like just slows down during the night, and your heart rate it can reduce slowly during the night, just like your glucose levels can, right? And then there's little volatility movements. And one thing that we do is kind of like scan up and down. Does the snoring match an oximetry volatility, match the pulse rate volatility? And you can kind of see that it does if you look up and down. Even the snorts they do match with the volatility. But it's not great. But there is some correlation that you can just visually see. And then the peripheral, this signal, I don't even bother looking at. Once again, these proprietary signals aren't as useful for me because it's just whatever the algorithm is calling. The hypnogram is, though, and usually, there's light sleep, deep sleep, REM. That's one cycle. Light sleep, deep sleep, REM. That's another cycle. Light sleep, and there's no deep sleep in this case, but REM, the third cycle, and then a fourth cycle. Normally, there's 4 to 6 cycles during the night. And in this particular case, there's 4 cycles. One thing I look at here is how often do they wake up? Oh, they woke up once, they woke up twice. A lot of people do wake up once or twice. That's normal during the night, just to wake up and go right back to sleep. So this is a little unusual. How can someone who has ultra severe sleep apnea at 65 interruptions per hour with trivial drops in oxygen, but yet they don't wake up more? It just doesn't seem to match, right?
How accurate are those waking? So like this waking up is let's say an elusive term because there's EEG waking up, right? Like measuring
Right.
very sensitively with EEG leads. How does that map over what the PAT gives? So these two, in other words, let me put it like this quite simply. The 2 wake ups that we can see here in PAT, would you expect that the EEG would show many more wake ups, or do you think this patient just doesn't really wake up from their sleep disordered breathing?
Well, okay, that's a big answer to that question. Listen, when you have a small respiratory event, you have a cortical arousal. Well, you can have a sympathetic arousal too, but you have a cortical arousal. By definition, when we score an event, that arousal has to be 3 seconds. Who came up with that number? Whatever, right? So basically, your brain has to go to a wake state for 3 seconds, and that's the cortical arousal. You won't remember any of those, okay? Just like you need a spark before a fire, but not every spark leads to a fire. Like you can strike a match, but not every strike leads to a fire. You need an arousal before an awakening, but not every arousal leads to an awakening. So you could have multiple arousals. The person looks like they're just fully asleep, but not actually wake up. But here's the interesting thing. Then the number of awakenings you have, what number of those do you even remember? So that's another thing. So you have a lot of arousals that lead to a few awakenings, of which you only remember a few, if any, right? And so the answer to your question is, a little complex, I suppose, but in this case, how accurate is it? Gosh, I don't know exactly for the WatchPAT. I don't have the data right memorized,
Like
but
pure speculation, but like I guess I kind of already asked this, so maybe this is redundant, but looking like what you know so far, the limited information you have on this patient, including the wake sleep stages that we're looking at right now, would you speculate that there's probably tons of cortical arousals if they were to have done a level one sleep study? Or is it, are we getting out of our lane making assumptions like that?
Well, what I think what well, if the data is correct and they have 65 interruptions per hour, 100% they have hundreds and hundreds of cortical arousals that did not convert to awakenings.
I
But what
see.
I'm
Okay.
saying is that's unusual. So
Yeah.
I'm actually questioning the validity of this WatchPAT, as you can tell. And like I said, I'm reading this live with you on, CPAP friend. So it doesn't make sense that you would have 65 potentially cortical arousals and only 2 actual awakenings, of which this patient may have remembered 0. It doesn't fit. This is someone I'd actually get a proper overnight study on.
Interesting.
But let's
Okay.
keep going just because, we want to be, complete. And so then the next page is the different positional data. Supine means back, prone, stomach, right, left, non-supine. And so, minutes each time, right? So the more minutes, the more valid the number is, as you can imagine, right? And then this is, so if you just look, whether you want to look at the ODI, PHI 3% or the PRDI, let's just look at the PHI 3%. On the back, I look at what's it on the back versus not the back. On the back, it's 56. Not on the back, it's 70. Once again, doesn't make sense. Does that make sense? This doesn't fit, right? Was this a bad study in some ways, right? And then we look at the right or left. Well, at this level of severity, I don't know if that's a big difference. And I'll go into it later on why I think right versus left is important. And in another study, I'm sure it'll pop up. But anyway, also a little bit of a red flag of why it's not worse on the back, because most people usually are a little worse, if not the same at least, but this person is better, which is a little unusual. And like I said, the snoring is not loud, 1.1 minutes above 60 decibels, which isn't bad. If I look at the sleep staging, the sleep is very light. So deep sleep is normally 15 to 20% of sleep. And this gentleman has 10%, so it's low. But deep sleep is also probably the least accurate, among the different staging from all these wearables. But still, it's, for what it is, it calculated as low. And the REM sleep is 24%, normal is 20 to 25. And then obviously light sleep is the rest of it. So that's sleep study 1. Severe sleep apnea, but I question it. I'd probably recommend the person gets an overnight sleep study before we throw the gauntlet of treatments and testing at them. Do you have any questions, or should we go on to number 2? Because we got 9 more to go through.
Yeah, let's jump on to number 2. I think we covered a lot with that patient.
Sure. And the rest should be a little quicker because we've already gone over a lot. So if we look at number 2, this person went to bed at 11:20 p.m., woke up at 6:20 a.m., recorded for 7 hours, and slept for 5 hours and 44 minutes. Ideally, you get 6 hours of data, but quite honestly, 4 hours is probably enough, right? As long as you can get 4 hours of sleep, is usually reasonably accurate. Now I'm just going to go straight to the numbers I look at, right? I look at the PHI 3%. Using a WatchPAT, how many times does this person completely stop breathing or partially stop breathing per hour with the 3% drop in oxygen? 10 times per hour. So remember I said 0 to 5 is normal, 5 to 15 is mild, 15 to 30 is moderate, 30 and above is severe. So this falls squarely into the mild category. But if you look at the non-REM versus REM, in non-REM, that 10 is actually 8.8 per hour. In REM sleep is 21.7. This makes sense. This person is worse in REM sleep, right? As at least it makes more sense. And the RDI, so basically using a WatchPAT, what's the respiratory disturbance index, meaning including arousals, is 19.8. So there are an additional 9.8 events per hour on top of the DSATs that it recognized that there are arousals, but the DSAT wasn't there, right? And in REM sleep, it was 48 times an hour. And that's substantial. So basically how I would call this is, I would call this mild to moderate, because the RDI is between 15 and 30, mild to moderate sleep apnea. And in REM sleep, it's actually moderate to severe sleep apnea.
Interesting.
Okay.
Yeah.
And then using the Medicare criteria, the 4%, you're normal. Get out of here. So anyway, whatever, we can.
I can't even.
So all these people that are suffering, all over the net, once you're 65, it's game over. No, I'm just joking. Anyway, but seriously, they will throw you, So let's keep going here. So let's go down here. So now let me pull this over here. So this is the average oxygen is 94%. I'm not a big fan of that. I like 95 or above. So, we always want to optimize everything, right? And then the minimum is 73%. That doesn't make sense. So whenever I see a huge disconnect between mild to moderate sleep apnea and 73, that's a severe drop in oxygen, right? And so that doesn't quite make sense. So one thing I'll ask myself is, was that a single spike? And if it was a single spike, it might be artifact due to movement or something like that, right? And you can see that, in fact, the 3 to 9% drops was 54. The greater than the 10 to 20 was 0, and the greater than 20 was 1. So that's probably not real.
Artifact, right?
It's artifact. It's movement artifact likely, or whatever, some kind of hardware artifact. And then how much time do they spend below 90%? Oh, 6 seconds, including the artifact. So that's not bad, right? So this person, even though they have frequent events, they're not desatting very much, and which makes me feel good. They could be highly symptomatic, but at least their risk of heart attacks and strokes due to hypoxia is less. The mean pulse here is 54. That's, they're probably in reasonable shape. It's a good mean pulse. The minimum is 44. The maximum is 92. Remember I said 40 to 90 is normal, the range? And this person's 44 to 92, which makes sense. The stress of the sleep disordered breathing just elevated them just a little bit. We'll keep going. And here, I'm going to skip over the parts I don't look at. Here you can see, hey, there's a cluster of snoring here, couple snorts here, another cluster of snoring here, couple snorts, and another cluster of snoring here.
Those really high snoring signatures, do you typically associate that with the typical gasp or end of an apnea, or why do you think those are artifacts? There's some of them that are completely isolated.
Yeah, it's 70 decibels, so it's loud, but I'm not in the bedroom. I can't confirm it. There's no audio feature on the WatchPAT that lets me listen. But I like I said, I try to validate it with the other signals. And so anyway, so if we look at the position, this person moved around a lot at the beginning. You can see they changed positions a lot in the first half of the night, and then became like Dracula, the second half of the night, just on their back, steady, right? If you look at the oximetry, looks good for the most part. And so this single spike is likely an artifact because it's not occurring in a cluster of other oxygen drops, right? So it's probably not real. And then it goes on. And then finally the pulse volatility, you can see that there's some volatility, but nothing extravagant, right? Except for this one here. And then the same deal, we scan up and down. Does the snoring match the volatility in oxygen, match the volatility in the pulse, right? And you can see loosely it does, especially this cluster here. You can see that, right? And then this cluster here, you can see that. And then the other thing we can look at is it worse on your back? So that this person was on their back at this position here, at this period, and then this entire period. Well, not really, because they're on their back here, and it wasn't worse the whole time. They're on their back here, and they were worse. They're on their back here, and they were worse. So for the most part, yes, but not always, right? And then here's their sleep. Oh my gosh, look at this hypnogram, right? So, light sleep, deep sleep, REM, this is one cycle. A normal cycle is 60 to 90 minutes. And that's crazy. This person didn't achieve their first REM until 4 in the morning, and then cycle 2. So only 2 cycles during the night. That's not normal. We want 4 to 6 cycles. And look how many awakenings. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Way too many. That's within the time they first fell asleep and the last time that they woke up. That's too many awakenings. And some of them were relatively longer too. The other thing I look at is, did they wake up out of deep sleep? So out of those 10 awakenings, one out of deep sleep, two out of deep sleep, three out of REM sleep. So three of the 10 took them out of the most, restorative periods of sleep, if that makes sense.
Interesting. Yeah. Um, yeah. What else can we say about that, if anything? Going from deep all the way to wake. Does that mean typically it's like a very severe moment of sleep disordered breathing?
Well, I think of arousals like speed bumps on a highway, or a road, whatever, right? And it doesn't let you get up to the speed, doesn't let you get up to the depth that you want. But if it's a big pothole or a big speed bump, you got to really slow down, right? And I think that's what those are. Those were substantial enough that they knocked you out of those stages, and that's not ideal because your body wants deep sleep. It wants REM sleep. It wants deep sleep for feeling vivacious, alert, giving that restorative sleep. It wants REM sleep for processing memories, information, and learning. Anyway, onwards, right? Because we're only on number 2, Andrew. Okay, and we may not even get through all 10. Who knows? And so we look at supine and non-supine. That's the first thing I look at. The AHI is 3.6, RDI 10.7, and in the supine position, 12.1 and 22.8. So basically, when this person is not on his back, it's mild, and when they're on their back, it's closer to moderate, right?
Yeah.
And they did not sleep on their right side. They slept on their stomach when it was only 37 minutes, but it was actually similar, and the left and stomach was not too different. So basically the big difference was on your back versus not on your back. And then so this person snored 1.7 minutes over 60 decibels. That's more than the person before that had 65 interruptions. Now you know why I question that WatchPAT. And I'm going to pause, and I'm not even sure if most doctors go through this level of interpretation of the WatchPAT. There's a technique on the WatchPAT that you can just see the main 4 numbers and just submit and enter, and boom, you're done. So
Really?
I'm just being frank with you. The insurance world is just clamping. There's less time for everything. I'd be shocked if any of the doctors doing the WatchPAT even looks at it with this depth, unless they're, somehow have a lot of time. But I do, because, I got 2 hours with each patient, so I go over everything. But anyway, 1.7, that's not bad. That's not that much, right? And once again, if I look at deep sleep and light sleep, deep sleep was okay. 15 to 20 is normal, but REM sleep was low. Normal is 20 to 25. So this person's not going to be feeling good. I mean, they're just not going to be feeling good. They're not going to be they're going to be kind of mentally foggy.
Yeah, between those two, can you add some color to that? Like, do you consider REM or deep one more important than the other, or do we kind of need both to feel good? Like, or let me put it like this: if you wanted to feel good the next day, would you want more REM or more deep?
If you wanted to feel good the next day, you want more slow wave sleep, because that's when growth hormone is released. That's when you are, well, there's some data conflicted, but that's when you really cleanse the brain. And that's why most of your deep sleep occurs in the first half of the night. And most of your REM sleep, even though there's cycles that contain all of it, most of the REM sleep is in the second half of the night. Okay, let's get to the business of getting through the restoration. And now let's get to the business of like learning and processing in the second half, right? Maybe that's too simplistic, but it's how I think of things, right? But both are important. It's almost like saying, hey, is my accelerator important or is my brake important? Well, I don't know. I like to go fast, but I want to stop too, So it's all good. It's all important. And yeah, so let's keep going. WatchPAT number 3, are we ready?
Let's do it.
Are you learning a lot, Andrew, through this or no?
I'm learning a few little things, but I know most of it.
You know most of it?
I
Okay,
did a
good.
WatchPat video. I don't know if you watched that.
I did not. No, I did
Yeah,
not. But, do you
but
think the audience would learn a lot from this then?
yeah, I do, especially because it's coming from you.
Oh, I see. I see.
Um, yeah, I did one. I went. It was really boring and tedious, but I was kind of thinking a similarly along the lines that you're thinking? Like people, they really want an answer about their WatchPAT, they can go to that video, but it kind of failed as a video. But this is different. I think it's the variance between the studies is a super important component that I wasn't able to present. I basically presented a, their
Okay,
their
how
their,
they
their
did
poster
that.
child WatchPAT or whatever that they give you on their website and kind of
Yeah, well,
explain.
hopefully what'll happen is people will resonate and say, hey, that's me. That's mine. That
Yeah.
looks, or they'll pull out their watch pad. Oh, Okay, onward. Sleep study, watch pad number 3. Okay, this is a female. Okay, we'll go there. So, person went to bed at midnight, woke up at 7 a.m., recorded for about 7 hours, and then slept for about 6 hours of that time. Normally, we want about in the lab, we like 85% or more of the time they're in bed to be asleep. At home, I like 90% or more sleep efficiency. So whatever, just a tidbit. Here, the AHI 3%, the PAHI 3%, using a watch pad. How many times does this woman stop breathing completely or partially, causing a 3% drop in oxygen? 4.3 per hour. Normal. Under 5 is considered normal. Now at the RDI, what's a WatchPAT respiratory disturbance index is 10.4. So this woman had few desaturations, oxygen desaturations, but many arousals. This is the standard diagnosis of upper airway resistance syndrome based on a sleep study. AHI less than 5, RDI greater than 5. In REM sleep,
Can I say
the
one thing here? The ASM conflated those two recently, didn't they?
what do you mean by conflated?
I don't they
Educate.
like don't they don't even make a distinction now between
No,
UAR.
no.
What do you think about that? Do you have any comments on that?
Um, I think the only difference is how people present. Does that make sense? I think it's the same spectrum of disease, restriction and nasal resistance and reduced flow but I think that people with hardcore sleep apnea, maybe they're more prone to high blood pressure, heart attacks, strokes, glucose level fluctuations, more the physiologic effects. And I think the UARS, kind of like a lot of arousals, but not too many DSATs, they get more of the, like anxiety, depression, ADHD, brain fog. They feel a little scattered. They don't feel steady. They're a little impatient, irritable, insomnia, things like that, right? I think that's what's important to distinguish between someone with a high AHI versus a high RDI. Now, the high AHI person can have all those things, but what happens is if the AHI is low, people get blown off. But the reality is that RDI can cause that pressured feeling in your body, loss of balance, because we all seek balance in the end.
So according to the ASM, then, if you have an RDI of 20 and an AHI of 1, do you have sleep apnea according to them, or
Yes,
what do they say?
RDI greater than 5 with symptoms is positive for sleep apnea.
Okay, interesting. Do you think they did a disservice by conflating those and that we should have kept a distinction, or do you think
No,
they were right
no,
on
no.
this one?
I think it's fantastic. I think whoever did it was brilliant, and the reason why I'm saying that is because now an RDI greater than 5 is positive for sleep apnea. Well, that's easy. That's not going to be difficult to
True,
get.
true, yeah. Okay.
And so, I mean, you have to have symptoms, but who doesn't have some symptoms, right? And then this woman during REM sleep is 7. That 4 became 7. The 10 became 20. And so, it became almost moderate in severity, at least in terms of RDI, in REM sleep. And once again, with Medicare criteria normal, no central apneas, that's all a win. Finally, an average oxygen of 95%. Great. A drop down to 87%. We'll see if that's real or not. Did it occur in a single spike or was it in a cluster? Time spent below 90%. Wow, that's 18 seconds, right? And below 88%, 6 seconds. So maybe that is real. Maybe that 87% is real because it seems like it's very, logical. The mean pulse is 59. That's right. Remember I said between 50 and 70 is most people. Minimum is 44, maximum is 96, should be 40 to 90. A little elevated with someone with sleep disordered breathing makes sense. And then um, and then if I look at the various charts, very kinetic sleep, one, I don't really have a flavor for when to call it kinetic or not. I just kind of look at it, but it looks like they move a lot. They're not just still, right? They're shifting a
Oh,
lot.
side question. I was looking at literature. My memory is very vague, but I was looking at literature that was trying to correlate the severity of subjective daytime symptoms and channels, objective channels. And I think movement was like either one or two, like highly, highly correlated
Oh,
with bad
sure.
sleep. Did you read anything like that?
No, but I mean, standard, I've done sleep studies for years. The more kinetic someone's sleep is, assuming they don't have PLMs or whatnot. And just to digress a little bit, that first study, I didn't really go into it, but the one with the 65 AHI, whatnot. I've seen occasions where periodic limb movements of sleep, these are sleep movements where your toe goes up, your ankle flexes, your knee flexes, and your hip flexes. Or if it's really bad, your whole body flexes, right? And I've seen, and then they can cause arousal sometimes if they're severe. I've seen instances where the WatchPAT is confused by severe PLMs. So it's WatchPAT study number one. The reason why I'd want a formal overnight study is, hey, did that person have PLMs, right? And it was miscalled respiratory events because
Gotcha.
the rest of it didn't make sense. Anyway, hopping over here, yes, the patient's sleep is kinetic, and there is a little bit of steady snoring, but also small clusters here, 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 here. Sleep apnea occurs in clusters, and that's what, it's kind of strange. And you can have this small airway, the same, fixed small airway, but regardless, it comes in clusters. Just like someone with epilepsy, they can have epilepsy and they can even have perhaps even an abnormality in their brain, but the seizures come in clusters. Hey, you have it for a few weeks, they disappear. Well, if it's all the air, if it's all the plumbing, if it's all the abnormality, why wouldn't it just be steady all the time? The body's pretty complex. So I look for that cyclical clusters of snoring. Does that make sense? I look for that. And it seems like this woman has it. And then we look at the pulse. Looks okay. I don't know if that one pulse drop to 80 or whatever it was is real because it did happen just by itself, right? And then we look at the pulse volatility, a little bit of volatility, and does it line up with the snoring? Yep, it seems to line up with the snoring. So this looks like a good valid study. And once again, wow, light sleep, deep sleep, REM, one cycle. And then not even a cycle of one, not even 4 to 6 cycles. And how many awakenings? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11 awakenings, more than the last person. And how many had a deep sleep? That person had three. 1, 2, 3, 4, 5. So 5 of the 11 woke them up out of either slow wave or REM sleep, which is substantial.
What does the literature say, or just even your experience or developed intuition say about when you do get aroused? There's variance between patients, right? Can some patients go, let's just say they went N1, N2, they get into N3, they get woken up. Some people can go right back, right? And complete the cycle, and others will go back to say N1 or N2 or something. How
Yeah.
does that work? Yeah?
It can. You're right. Absolutely right. You can have an arousal and it could take them out of the entire cycle, like out of REM or out of slow wave. You can have an arousal and they just go right back into it. I don't know. I don't think there's any literature as to why that occurs, right, for some people versus others. And that's where the arousal threshold maybe comes into play. Different people have different arousal thresholds. This woman, definitely has a light awakening threshold, at least, right? It seems like a lot of her arousals are converting to awakenings, and it's very sensitive. Um, anyway, if we look at the non-supine versus supine, it's 9. The RDI is 9 not on the back, and then 12 on the back. Makes sense. And then it didn't matter if they're prone, right, or left. Very similar. Okay. And then snoring over 60 decibels, just 48 seconds, not that much. And then REM sleep was light. Like I said, should be 20 to 25%. Deep sleep was adequate. Let's go on to sleep study number 4. And then here we have person, is it a male or female? At least we can identify them correctly, female. And so, they went to bed at 9:30 p.m. Wow, actually a normal time to go to, a decent time in today's age, right? And woke up at 7:20 a.m. It's amazing. 9 hours and 45 minutes in bed, 8 hours of sleep time. Not the greatest percentage, but pretty good. Once again, we have a UIRS patient by the numbers. The AHI 3% is 3, right? So, And the RDI, so under 5, the RDI is greater than 5, which is 10.6. So this will be the, once again, classic URAS. And similar to the last patient, wow, it doubled in REM sleep, right? Twice as bad in REM sleep. So it seems like a valid study. Great oxygen, mean oxygen, 96%, right? And the low is 93%. So when these DSATs occurred, they occurred from very high level, 97 to 94, 96 to 93, very high level DSATs. How much time below 90%? Zero. The mean pulse is a little high. I don't like that. I mean, I know 50 to 70 is normal, but I like, there's a study that shows that for every 1% higher average heart rate you have at night, it equates to a 3% greater sense of anxiety during the day or stress.
Interesting. Can you
So the
say that
lower
one?
your mean heart rate is at night, the better.
Interesting. Very interesting. I did not know that.
And so I look at that and I say, that's a little high. So start working out. Aerobic is the best because that'll really, get it in shape. But weights are important too. And then the minimum pulse is 48. The maximum is 112, a little elevated, right? But over the 40 to 90. The graphic shows the AHI in the normal range, but obviously the RDI is in the mild range, right? Which it doesn't show. You can see, like trace snoring all through the night with a couple, cluster, 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 cluster. And you can see that the oxygen is more or less okay. The WatchPAT algorithm took out the 80% drop automatically, right? And kept, so it actually was smart enough to take those out as artifact. And that's why I said it was above 90. And the pulse volatility matches the snoring, as you can see from top to bottom, right? And then once again, these are the, remember I said about the URS patients? It's not the heart attacks and strokes. It's look at that. Just look at that mess, right?
That looks like a horror show, honestly.
Yeah, and and I'm telling you, the team brought up 10 sequential studies that I read. I just said pick 10 in a row. I don't want to look at them. So that's why I seem surprised every time I look at them, right, with you. Because 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17 awakenings within. Let's say how many of them were from deep sleep or REM sleep, 1, 2, 3, 4, 5, 6, 7, 8. I mean, yeah, 8. So I can't remember how many she had at the beginning, 17, whatever. That's a lot. So that's a lot.
Yeah.
She's being punished at night. It's really sad. And like I said, if you go to a lot of ENTs with this, oh, your AHI is normal. Get out of here. And I'm suffering, right? And that's anyway, so we look at here, so this is interesting. On the back, it's not worse than on the side. So that's interesting because a lot of times we think when you're on your back, your jaw falls back, your tongue falls back. So maybe it's not this woman's jaw or tongue or something like that. But I do think the data is real because everything else has been fitting, right? But what's interesting is this. Look at the prone versus right versus left. Prone is 11 events an hour. Right is 10 events an hour. These match, but left is 23 events an hour. When you see a difference between the right and left side, do you know what that means, Andrew?
Nasal breathing differences?
Yeah, 100%. That means one side is obstructed. And when you sleep on the obstructed side, your breathing is good. When you sleep on the good side and you not on the obstructed side, your numbers get worse. So because the left side is 23 events an hour, the number is much worse when this woman sleeps on her left side than the right side. So what that means is the left nose breathing is much better than the right nose. And when she slept on the left side, gravity blocked the left side. And now she's got a blocked up left side, which was good, as well as the blocked up right. So when I see this, I would suspect that this person has a right nasal obstruction of some type, deviated septum, or just massive nasal cycling that occurred at that time. What's it?
And let's note too that we can measure this now, right? We can objectively measure nasal resistance and nasal flow. So you can confirm this. We don't have to play a guessing game and go get 10 nasal surgeries. We can find out for sure, right?
Yes, you can do rhinomanometry and you can have that checked. You can do a cone beam CT and just look and see what's happening. Anyway, so I'm glad this happened. So, your audience can see what the difference is. So it's okay that so this could be a nasal problem. All of this could just be a nasal issue for this woman. And then once again, deep sleep, light sleep was a little bit low in REM sleep, 20 to 25% is normal. And in this case, it was 18. Sleep study number 5. We're almost halfway. Okay, let's go onwards, right? This person went to bed at 10 p.m., woke up at 6 something and change, 8.5 hours of sleep, almost 8 hours of recording time. Pretty good sleep efficiency. I'm gonna go a little quicker because I think people are getting a hang of this, right? The PHI 3% is 20. That falls into what level? That would be moderate sleep apnea. 15 to 30 is moderate. The RDI is not that much greater. So I would just call this straight moderate sleep apnea. Didn't really matter if the person was in REM versus non-REM because the numbers are similar. And no central apneas, right? 0.1, that's all good. And then so I only look at the Medicare numbers if the patient is older and needs to look at it. Average oxygen is 97%. Excellent, right? That's solid, right? You get so used to these 94s, you think they're normal and they're not. Minimum is 90%. But what that means is that minimum is substantial. So when you drop from 97 to 90, that's even though, 90 is not bad, but if your average is 97, 90 is a big drop. So that's what you should walk away with. So how much time below 90%? 0. The mean pulse is 65, right? Which is a little bit, elevated. And the range is 40 to 90. And this person was 51 to 99. So a little bit elevated. Everything's a little bit elevated, right? You can see that, wow, tons and tons and tons of snoring. Chain snoring. This is the freight train snoring, right? All through the night and loud. But surprisingly, doesn't move all that much, not entirely that kinetic of sleep. Does that make sense? Like, because you do change positions here and there. You have to. Even someone in the hospital who's in a coma, you got to move there every 2 hours. You have to move, otherwise they're going to get a decubitus ulcer. So
really, it's every 2 hours you have to move someone like that.
I'm just saying that. I don't know what the exact numbers, but it's somewhere along that lines. So what I'm saying is, okay, if you think of it that way, you should at least have 4 movements during the night, right? Minimum, right? So this isn't over the board, but a lot of snoring. And then we looked at the oxygen levels, and it does look like it correlates with the heavier snoring. You see that? Like the volatility, and the same thing with the pulse. So once again, seems like a valid study. But interestingly, see these apnea patients, they may not have as much sleep fragmentation as the UARS patients. Isn't that interesting? Like more events, right? The AHI is much higher, but they're more DSATs and more, it's loud snoring DSATs versus that. But anyway, 1, 2, 3, 4, 5, 6, 7 times versus 17, the last person, right? And then how many of them woke them out of deep sleep? 1, 2, just 2.
I got a question. Right? I got a little side question for you.
Maybe 3. Yep.
Do you ever see, so like there's a bifurcation in symptoms, right? There's the URS, like super sensitive, all these cognitive consequences. Then on the other side, like you mentioned, there's like the hypercapnia, cardiovascular risk, hypoxemia, hypoxia, etc. Are there some patients who have, let's just say, really high thresholds of arousal? Their data looks horrendous. They desat all night, but they feel good because their sleep architecture is proceeded through without the same level of disruption because of a high threshold of arousal. And they have no interest in going on CPAP because they feel the same basically, or they can't tell, or are there people like that?
You nailed it. Nailed it. Yeah.
Yeah, I thought so.
Like go ahead.
Yeah, I was just gonna repeat basically what I was saying, but like just terrible data. But for some reason, they're genetically gifted and they just sleep through all of it. And they just go through all the sleep stages, kind of okay, good enough. and they wake up and they feel fine. They never want to address it.
Yeah, you nailed it. And the number one reason why people pursue treatment is to feel better. And the number one reason why they continue, for instance, CPAP, is it makes them feel better. But yeah, it's tough when someone has pretty bad apnea with significant hypoxia and they feel fine. And you're seeing it right in front of you. Someone with more significant apnea is physiologically experiencing fewer awakenings. I mean, you're seeing it right there in front of you. And so it's complex. Why? I don't think they've ever looked at. There's so many questions. The ratio of what we know to don't know is always close to zero. And once we step back, we're good, right? Anyway, so then we looked at this, and you can see that this. What jumps out at you, Andrew? This is primarily. Look at these numbers. It's primarily
On the back.
on their back. 53 events an hour on their back, and on their side, this is like Jekyll and Hyde. I can't remember which one was the bad one. But anyway, but yeah.
Does that say anything to you? Like, not with 100% certainty, but can you start to get an idea of what the problem might be anatomically for this person?
Well, then it's just gravity. It must be the jaw, the tongue. It must be the pharyngeal airway collapsing. It's not really the nose as much in this case. Now, it's like Bernoulli's principle. If you have a tight nose and you suck harder, it could collapse the pharyngeal airway. But it's that jaw that should be based on this, that should be the issue. Anyway, the amount of time above 60 decibels is 7.8 minutes. This is solid. Because that's loud. In our local ordinance here in California, if you have a leaf blower and it's over 60 decibels, you get a ticket. It's banned. I don't know about the rest of the nation, but in California, it's at least in my county, it's banned.
That's hilarious.
Um,
So they got to keep their window closed, right? Or the cops are going to come over.
They got to keep their window closed, or yeah. They may ticket you. I don't know what that does to CO2 levels or anything, but anyway, so the REM sleep is 20 to 25, looks great. Deep sleep 15 to 20 looks fine. So see, like you said, this didn't impact them. You're right. This person might walk in the office, oh, I feel fine. I've gotten along this long without it. Sleep study number 6. We are over halfway. We are on the second half. And so went to bed around 9 p.m., woke up around 6 a.m., 8.5 hours of recording time, 7.5 hours of sleep time. AHI 3% is 23, RDI is 23. So moderate sleep apnea, much worse on their during dream sleep, 43 times an hour. So it became severe during dream sleep, 30 and above is severe. Mean oxygen, unfortunately, is 93%. That's not good. Take away the whole sleep apnea. Now, the only question I have is, was it the repetitive oxygen drops that dragged that average down, or is it just that they're low? And then you have to look at pulmonary. Then you have to, what's their pulmonary function test show? Do they have any other disease going on? Do they have a lower airway issue versus an upper airway issue? Anyway, the minimum oxygen was 83%, which is low. And the time they spent below 90% is 7 minutes. 88% is 3.2 minutes. 85% is 0.3 minutes. Uh-oh, that fits. Gets less and less and less, right? Mean pulse is 61. Range is 40 to 90. For whatever reason, their heart rate did not vary. But what does that tell you? There's also a problem with that. Heart rate variability is your heart's ability to change, to acclimate to each stress. So when you take a breath in, the heart rate should go faster. And then when you exhale, it should go slower. When you run, the heart rate should be able to go up. But this is actually a bad sign. If I don't like it if it goes up too high, but if it doesn't go up too high, I'm going to say, oh, well, you may have less heart rate variability. Does that make sense? Like your cardiac system may not be able to I guess, like react to the stresses being presented to it. It looks more ominous now, doesn't it, Andrew?
Yeah. So
yeah.
Is that something that's developed or genetic? Like, is this person's body, like maybe they've had this for so long and the brain is kind of switching lanes and going, you know what, like I'm not going to respond to this every time and it's giving up? Or could they just be unhealthy and they don't have a strong cardiovascular system? Or could we not really say anything about this?
Honestly, like if you want to be the best practitioner, you'd be a master at the air. I feel like I got a few things down, but you'd also be a master of the lungs and a master of the cardiac system because all three are involved, right? And when it gets to the lungs, my knowledge base goes down. When it gets to the heart, my knowledge base goes even lower. And but so I don't know the answer to why, if it's developed, the poor heart rate variability, if it's like once you treat the sleep apnea, we know heart rate variability improves, but does it get all the way back? Just like your brain, does it restore all the way, or is there some damage that's left, right?
Okay.
I don't know the answers. I'd like to find out, but I just
I try to make like URS patients feel a little bit better and say, the redeeming quality is that your body is waking up when there's a problem. It cares, it's reacting. It's
yes,
it's like
yeah.
it's a blessing and a curse. You destroy and fragment your sleep, but you're not living a life of hypoxia, right?
Yeah. Yeah. Fear is safe in some ways. And so is allergies, like reacting to the environment. But sometimes it just, like you said, it turns a corner and gets worse. You can see that their snoring is just light snoring, surprisingly, right? Overall. And then the sleep was fairly like the first 2/3 of the night is pretty stable. The last third is just, a lot of awakenings, terminal, kind of like the terminal insomnia. And then there's some fluctuations in the pulse, and then sorry, in the oxygen, some volatility, and then there's some volatility in the pulse too. And they do line up, so that makes sense. And then awakenings wise, 1, 2, 3, 4, 5, 6, 7, 8. You can see how I normally count. I want 1 or 2. No, that's what I want normally, 2 or less. And then 8. How many woke up out of deep sleep? Just 1. So not bad, right? So and does that mean anything? It's just something I look at, but does it, but I would guess that it does mean something. No one ever looks at your awakenings from what stage and doesn't knock you out. And then once again, this is very positionally related. Most of the events, 31.8, were on the back versus on the side, 11.1. We don't have right-left differences because they never slept on their left side. Prone versus right was no different. Above 60 decibels, 1.1 minutes, which isn't that bad. And then REM sleep, 20%, 20, 25 is normal. Deep sleep, 70 to 20, 15 to 20 is normal. 17 is fine. But at the lower ends are normal, but still okay. Sleep study number 7. And this person went to bed. I don't know who this person is. 8:50 p.m.
Wow.
In this society, that's amazing. But it's an early bird. This is a lark. Wakes up at 5:45 a.m. and slept. My God, look at that sleep efficiency. 9 hours, just only, he was in bed, or she, whoever it is out. Once again, a URS patient. AHI less than 5, RDI greater than 5, and in REM sleep, a little bit worse, right? As you can imagine. Minimum, the mean oxygen is 95%, the minimum 75. Probably not real, but here's the problem. 0.3 minutes under 90, 0.2 minutes under 88, 0.1 minutes under 85. Maybe it was real because it looks like it's, there's some additional, time or whatever, there's a nice flow to that.
Yeah, is what you're saying, like if you have a minimum, let's say that's low, what you're looking for is, well, what is
Like
the
a bunch of zeros, and then 1, or something like that here, right? Like it doesn't make sense if it's just a one-off.
right?
But it looks like, hey, 18 seconds under 90%, 12 seconds under 88%, and 6 seconds under 85%. Well, that makes sense, right?
Right.
And then the mean pulse is a little bit, I mean, normal, but I think, not the best, right? Like I said, the lower the mean pulse, the more calm you are during the day. So that's what you want, right? And so sleep isn't just about deep sleep, light sleep, and all that too. You got to look at everything. You got to look at your breath rate. You got to look at your pulse rate. Anyway, minimum 40, maximum 117. Bad news is it went up. Good news is the heart reacts, right? So, I mean, it's all how you look at it. And then there's some steady snoring here during the second half of the night and some clusters in the first half of the night. Pulse is pretty solid. I actually don't believe those pulse drops. Does that make sense? If I looked, was it any central apneas? It's just a few. So not clear what this is. It could just be artifact, actually, because it's not occurring in a cluster. But you can see the snoring definitely correlates with Like this person has good heart rate variability, it seems like, because they're just highly responsive to the snoring, like the pulse really shoots up. And I think your heart rate, my guess is your heart rate probably, like you said, this is a guess, but it probably does respond until it can't respond. It just gives up, right? It's just like in sleep apnea. If you look at the tensor palatini muscle and the genioglossus, in a normal patient, in a sleep apnea patient, those muscles are actually elevated in intensity or in activity. And then the thought is at night, they're more elevated, but it's like endurance. They just finally give up, right? Versus a normal person is not elevated, and at night it goes up, but it's fine because they haven't been working all day also, right? Little digressions, but I thought, tidbits that are
I
interesting.
like little digressions where
Okay.
all the flavor is, you know?
And then so awakenings, one, two, just three awakenings. That's it. So, and then one cycle, two cycles, three cycles, four cycles, five cycles. Great. And none of the awakenings occurred out of deep sleep. So not bad, in terms of, maybe it's bad because they don't feel as much, possibly, but and then you can see that it wasn't worse on the supine position, but here we go. This looks like more of a nasal problem, possibly, right? It's the left side was worse than the right side. So they probably breathe well through the left nose. They sleep on the left nose and now block their good side. And now the number went up sky high. Does that make sense?
Yeah.
Okay, good. So we've seen two of them, 2 out of 7, right? That were like that. And maybe one bad WatchPAT that was possibly due to PLMs instead, the first one. And then here, the deep sleep was like 15 to 20 is normal, 14.92 is low. Ready for study number 8. I told you we go through them quicker once we get through them here. And so this one went to bed at a decent time, 9:30 p.m., woke up at 6:30, 9 hours of recording time. Sleep efficiency is decent, not the best, but decent. And then this is a mild apnea. So just an AHI of 6 and an RDI of 7. Just mild. Everything's hugging. In REM sleep, a little bit worse, 10 to 13, right? The AHI and RDI. Mean oxygen is awful. So it's either it's the other question is it real? Like, was it just a bad sensor, right? But if that's real, that's not ideal, right? That is low. But we don't know if that's real or not. And nowadays you can just buy so many finger ring oximetries that are so easy to confirm or refute this. And the minimum is 82. But if this is inaccurate, and this should have been 95, 96, and this would have been 85, 86. So, you gotta kind of do the mental calculations. But once again, 54 seconds underneath 90%, 48 seconds under 88%, 24 seconds under 85%. So maybe, maybe it's real, right? It looks like a nice, progression. Pulse is great, 51, love it. 40 to 90 is normal. Didn't change much at all, right? Only went to 74, but because it's mild, that could just be fine, right? And then you can see here little clusters of snoring, 1, 2, 3, 4, 5 clusters of snoring. And this one caused some volatility in pulse. And you can see the pulse kind of hugged low.
You mean SpO2?
Sorry, yeah, it's SpO2, yeah. Hugged low and then kind of went back up. I don't know. It's hard to tell if that's real or not, but it's hard to tell. That's why obviously you meet the patient, you get a history and all this other stuff, and if needed, you confirm that. And then the pulse, very little volatility, but also there wasn't much apnea, so maybe is it poor heart rate variability or is it just a little not as much apnea, right? And then, but they do wake up a lot. 1, 2, 3, 4, 5, 6, 7, 8, 9 times. And out of deep sleep, 1, 2, 3 times. So in my opinion, it's just like I said when I think we had the other talk, we look at different parameters to diagnose sleep apnea. Even in a sleep study, what's the AHI? What's the RDI? What's the mean heart rate and heart rate, differences? What are the DSATs? How many times do they wake up? How many times do they wake up out of a deep sleep, versus REM versus slow wave sleep in particular. And then here you can see that it's normal when they're not at least the numbers are under 5, when they're not on their back, and a little abnormal on their back. And then once again, this person, it could all just be nasal. It's 6.4 on the right side and 2.9 on the left. So if it's worse on the right, that means the right must be the good nose. And they sleep on the right side, plug it up with gravity, and now their numbers go up. So maybe this person just needs a quick cone beam CT, look at their nose, or an rhinomanometry to confirm it, right? And then voila, you fix it, right?
Small
Hopefully.
digression. I'm getting maxillary expansion now. I can already tell it's a huge difference. I've had to lower my pressure. My sleep is way better. I can
Yep.
breathe through my nose way better.
Yeah.
And you can see, like, well, I don't know how good the picture is, but
Oh yeah. And it
it's a
looks symmetric too.
it's nice and clean and symmetrical so far. Yeah. But even with such little change, I notice a huge difference in my nasal breathing already. And
Yeah,
I've
that's
I've had to lower my pressure. I mean, already.
yeah. And when these surgeons, and you've interviewed, I mean, I see these interviews, some of these top surgeons saying there's no data on maxillary expansion. I don't know. I mean, I have yet to meet one patient who hasn't really noticed a benefit.
Yeah. I mean, I just think they're out to lunch. I mean, the
They're
data's
out to lunch. I think they're so myopic in the surgery part that they don't see the patients before, they don't see the patients after. They just do their surgery and then that's it. And then they speak as if, and then they wait for the literature to show up. And if it's not there, anyway, but I agree
the
with you.
the one thing I've noticed with all the people who are in the vanguard of sleep medicine is they say the exact same thing. Nasal breathing is everything. Nasal breathing is everything. You have to be able to breathe through your nose. If you can't breathe through your nose, it's all wrong because you're
And
opening your mouth. Your mouth needs to be closed when you're sleeping, right?
yeah, and maybe poor nasal breathing doesn't cause apneas, but it can definitely cause, I believe, reras and hypopneas with arousals. Does that make sense? And so, anyway, just Bernoulli's principle. And so, above 60, 1.7 minutes. So you get the idea. If it's just a few minutes above 60, big deal. Not a lot of snoring, right? And then deep sleep was good. REM sleep was a little bit low. 20 to 25 is normal. So, but still, lower end of normal numbers. Sleep study number 9. Okay. I'm sure your audience is going to be sick of these WatchPATs, but at some point they should have a good
Yeah,
grip.
congratulations to anyone who's on number 9 with us here, right? Send your application to
You can
Anil
just
Rama.
slice it up into 10 WatchPATs and put 10 videos up for those who have lack of attention, which anyway, 11 p.m. When they went to bed, and this could be me. This is when I go to bed and wake up. Anyway, but they slept most of the time, which is good. And you can see that they have mild apnea, AHI 9, RDI 11, both are within 5 to 15, so I'd call it mild. In REM sleep, it's moderate. Both are in the 15 to 30 range, right? 20 to 23, which is for moderate. No central apneas. The mean oxygen is 94. I'm not happy with that. I like 95 and above, right? And 89% is the minimum, and the only 6 seconds spent below 90%. Pulse is 53, which is good. That's a good pulse. Range is 42 to 83. It's fine. 40 to 90 is normal. So a little bit of mild apnea, and you can see that it's very just based on based on the positional data. You can see that when they're on their back, lots of snoring, and then I guess they're on their back here, but still more snoring on their back overall. Even here, this little part here, and then this part here, and then this part here. You can kind of see that a lot of times when on their back, the snoring gets really bad, and you can see the drop in oxygen. You can actually see a little bit, right, each time. It's not perfect, but you can kind of see it. And then once again, the pulse rate is volatile during the periods. But it's interesting that it wasn't volatile during this period of snoring. Isn't that interesting? Like why it wasn't like more like in this period, it was very volatile. And in this period, it wasn't. It was initially, and then it stopped becoming volatile. And then this person, 1 cycle, 2 cycles. I'm never sure if this is all 1 cycle because the REM came pretty closely. So this could be 1 cycle. So 1 cycle, 2 cycles, 3 cycles. This is all one, and 4 cycles, but not ideal. The REM cycles are broken. Does that make sense? Like in other words, within the cycle, the REM should be consolidated, and it's not, and it looks like it's broken. And then and the And the deep sleep, when it's achieved, it's just very minimal. It's short. And anyway, and then they wake up once, they wake up twice, they wake up 3 times, and that's it. So they woke up 3 times during the night. And yeah. Uh, okay. And then and out of those times, one was out of deep sleep and two was out of deep sleep. Actually, yeah. Yeah, only actually 2 of the 3 were out of deep sleep. Here, worse on their back, so it could be their jaw and tongue and everything else, right? But also a positional difference, so it could be their nose. And which side would be worse, Andrew? This is a pop quiz. Which side is their breathing? Which nose is better? Which side, right nose or left nose is better? If their apnea is worse on the right side. Hey, you're muted. I can't hear your deliberations.
My bad. Can you hear me?
I can hear you now.
Wait, so if it's worse when they're on their left, that means their good
No, it's worse
nostrils.
on their right. It's worse on their right side. 9.9 versus
Sorry, what am I?
5.5.
Oh, I see. So
It's
if
worse
it's
when they're
worse on
lying
the
on their
right,
right side.
that means
That,
when they're on their right nostrils downwards, it's congested, which means the bad one is available, which means the right nostril is better breathing, right?
yeah, exactly. Hot dang, Andrew. I don't know. I hope the audience is sitting there asking, "Oh, which one is?" Okay, good. Hope everyone
No,
got the
I think
answer.
they are. It's a little bit. It's one of those things that's kind of reversed. You know, you got to think about it a little bit.
Yeah,
There's a
yeah, yeah. But if you did it, you don't have to worry about dementia. Not today.
exactly the dementia
Okay.
test, litmus
Yeah,
test for
yeah,
dementia.
exactly. Which side is worse? Okay, anyway, and then 24 seconds greater than 60 decibels. That's not much at all. Deep sleep, light sleep is normal. And finally,
Wow, we did it.
sleep study number 10. And what we're looking at here is okay, well, we got
Wow.
a severe apnea patient, 42 to 45 events, doesn't change in REM versus non-REM, but doesn't go down at least, right? Does that make sense? The reason why is a lot of PLMs, a lot of periodic limb movements occur in non-REM sleep, not REM sleep. So remember that first study of 65 events an hour? There are fewer events in REM sleep. That's also a clue that the watch
Oh,
was actually capturing PLMs as respiratory because you have fewer PLMs in REM sleep. If usually, if any, almost all the PLMs are in non-REM sleep.
interesting.
Almost all of them. So the fact that it was less during non-REM sleep, the oxygen desat wasn't bad. I keep going back to that first one. I wish that was the last one. I should actually change this order now that I'm looking at this for the first time with But anyway, because that would have been a lot to learn from it. But we started with the crazy one at the first. Anyway, so average oxygen 93%. That's not good. Like you need oxygen for everything. And then the minimum is 82%. And unfortunately, this looks real. 249 between 3 and 9% DSATs, 19 events between 10 to 20, one greater than 20, 12 minutes under 90%, 6 minutes under 88%, 18 seconds under 85%. Pulse rate is 58, range is 40 to 90, and 43 to 104 it's fine, it makes sense. You can see it's just chain snoring all the way through the night. Doesn't matter if they're on their back or their side, whatever. They are non-discriminatory with their snoring, and their sleep is highly kinetic. You can look at that, right? Your audience should be able to see that and say, "Oh, that's kinetic." They're moving a lot. So this person, well, let's see, and then their oxygen sats. There's clusters of DSATs right here. 1, 2, 3, 4, 5, 6. The pulse is volatile through the night. And then, but here you go. Here's the Andrew special. They don't wake up that much. 1, 2, 3, 4, 5 awakenings during the night. Just 5, right? So, and then how many cycles? 1 cycle, 2 cycles, 3 cycles, that's not terrible, but 4 to 6 is better. And then they woke up out of deep sleep 1 time. I mean, meaning REM 1 time, and then slow wave sleep 0 times. So yeah, I don't know. I would love to have the person's symptoms next to it too, then you can really correlate, try to make some correlations between some of this stuff. But I don't, and then you can see that this person is far worse on their back, and on their stomach, they're actually much better. But it's only 22 minutes of data, so we can't tell that much if it's real or not. Greater than, this is not someone that's probably sleeping in the bed with their spouse, if they have a spouse, right? Because it's 30 minutes, greater than 60 decibels. That is a lot to bear. You know, true love goes so far. Anyway, and then you can see that there's deep sleep, 15 to 20 is normal. This is 9%, you know, that's just low. And so, you know, this person will age quicker. But there you have it, Andrew, 10 WatchPATs. And I can't imagine that someone who has a WatchPAT isn't a WatchPAT expert by now in reading their own WatchPAT.
Yeah, I feel like we covered everything under the sun and then some.
Yes,
But
yes.
I actually learned quite a few things, so I think people are going to learn a lot of things. Yeah, there's some things, interpretation angles that I wasn't thinking about at all when looking at these things. So Reddit, these are popular on Reddit, right? Because a lot of these patients are getting watch paths, and then they get the results and they go to Reddit and they ask everyone on Reddit. And you know,
Yeah.
the collective hive mind over time has gotten to be a pretty good WatchPAT interpreter. But some of this stuff that we covered today, I haven't seen there. So
Oh, interesting. I don't know. I don't go to I don't know how they interpret it, but Reddit has some very intelligent people on there. You
yeah,
know,
yeah, it's the beautiful thing about the internet. That's why I try to strike a balance in my messaging, of course, so you don't want to completely disregard the doctors, but I've met so many people on here that, I mean, who all come together from across the world, and they've been trying to figure this out, data driven. Some patients I have that I like with CPAP optimization, like the data structures and schematics that they present to me, I can't even believe it. I'm like,
yeah.
this is like an undergraduate like honors project, and you're just showing me your data. So yeah,
Yeah.
you're right, you're right.